A very warm welcome to this symposium, which will focus on the role and the contribution of an algorithm and scoring for the diagnosis of TB in children. My name is Eric Wobudea, and I'm a pediatrician and epidemiologist and a researcher at the Muju Research Collaboration and the Mulago National Referral Hospital in Kampala, Uganda. Sabine is my co-chair. She's a medical officer in WHO Global TB Program, focusing on child and adolescent TB. While all efforts should be made to confirm the diagnosis of TB in children through the use of child-friendly specimen collection methods and access to the most sensitive molecular testing methods, the decision to start TB treatment often relies on clinical judgment, guided by several parameters. Existing diagnostic algorithms have not been systematically evaluated due to the absence of a robust TB reference standard in children. This session will review recent evidence and future opportunities for more efficient diagnostic algorithms or scores to guide TB treatment decisions in children. To start this session, Sabine will introduce the first three speakers. Over to you, Sabine.
Thanks so much, Eric. So our first speaker is Jackie Oliwa. She's a pediatrician and clinical epidemiologist, currently based at the Kemri Wellcome Trust Research Program in Nairobi, Kenya, and the University of Amsterdam as a research fellow. Her work focuses on understanding and improving case detection of TB in children in Kenya. She will present on challenges in diagnosing TB in children and shortcomings of existing diagnostic algorithms and scores, exploring TB diagnostic practices among pediatric admissions in Kenya, using a conceptualized care cascade based on the national TB guidelines. Unfortunately, our second speaker, Louis Cuevas from the Liverpool School of Tropical Medicine, had been unable to record his presentation due to Liverpool being extremely hard hit by the second wave of COVID-19. But fortunately, Louis has been able to join the panel today, and he will provide a brief summary of his talk at the start of the Q&A session after the recorded presentations have been played. Then our third speaker is Olivier Marcy, who is a clinical epidemiologist and researcher at the University of Bordeaux. He has worked for more than 10 years as a clinician, researcher, and public health program manager in sub-Saharan Africa and in Southeast Asia. His research focuses on diagnosis of TB in children, as well as TB-HIV co-infection in adults and children. He is one of the coordinating investigators of the Unitate-funded TB Speed project. Olivier will speak about the new TB diagnostic algorithm and score for children with HIV infection and children with severe acute malnutrition. And Eric will now introduce our last two speakers. Over to you, Eric.
The next two speakers. Norbert Henrich is a pediatrician and a TB clinical trial specialist at the Ludwig University in Munich, Germany. He is involved in TB diagnostic validation trials for refugees, children, and for prediction of TB in asymptomatic household contacts, as well as TB in TB drug trials in the Panacea Consortium. Norbert will present interim results from the RAPID study in terms of the performance of new screening and diagnostic tests in potential pediatric TB diagnostic algorithms. James Seddon is the other speaker. James Seddon is a clinical senior lecturer at the Imperial College London and a honorary associate professor at Stellenbosch University. His research focuses on children with TB in both high and low resource settings and includes clinical trials, epidemiology, immunology, pathophysiology, imaging, mathematical modeling, diagnosis, and treatment. James will discuss which children should be evaluated with chest radiography, as well as new developments that could facilitate the use of chest X-ray in high-burden countries and resource-limited settings for the diagnosis of TB in children. Sabine.
So we'll watch the recorded presentations now. Enjoy.
So hello, everyone. Just before I start, my conflict of interest statements. I am an ideal research fellow, which is part of the Delta scheme of the Wellcome Trust, and I've received honoraria or consultation fees for various projects that I've done. So my name's Jackie Narotso Oliwa, and today I'll be talking to us about challenges in diagnosing TB in children, shortcomings of diagnostic algorithms, and scores. So by way of introduction, TB is one of the leading causes of death in children worldwide. The WHO estimates that there are 1.1 million cases and in children less than 15 years, and this represents around 11% of all cases, with 205,000 deaths, and this represents around 14% of all TB deaths. The true burden is, however, unknown. TB is a hidden epidemic, and it's thought that up to 60% of cases go undiagnosed. Now, one of the largest challenges is difficulty in making a diagnosis. So we'll go through overviews of the challenges in diagnosing TB in children. So we know TB symptoms vary and they overlap with other common childhood diseases, especially pneumonia, malnutrition, and HIV. And more often than not, this may actually coexist with TB. The classic symptoms of cough, failure to thrive, fever, lethargy are non-specific, and they may actually lead to overdiagnosis if used alone. Chest X-ray is difficult to interpret. There's variable imaging quality, lack of experts, especially in low resource settings where we do have, unfortunately, the higher burden of TB. And even where there are experts, there's widespread variability in interpretation of findings. Then there's also sporadic availability of tests like tuberculosis skin tests. We often have stockouts of gene expert cartridges and challenges in interpreting findings. This image here is just to show a child with fairly advanced TB disease, and mortality is high from a curable disease. So going on with the challenges, we know in children, and this leads to difficulty in bacteriological confirmation, often because of the low yield. We have challenges in specimen collection as well. Children produce small amounts of sputum. They tend to swallow their sputum, and they also lack the tussive force required to collect the specimen. So because of this and other challenges in diagnosing pediatric TB through clinical signs and symptoms, radiological studies or lab exams, point-based scoring systems or diagnostic criteria are often used to assist in the diagnosis of TB in children. So we'll just get a brief overview of TB diagnostic systems that are in children. The first point-based score system was introduced in Chile in 1969 by Sturgeon et al. Since then, there have been various other systems developed, but the WHO criteria originally published in 1983 are the most widely used. So some of the challenges of diagnostic systems include variability in clinical definition. So for example, chronic cough. Is it cough that's been there for more than 2 weeks, more than 3 weeks, more than a month? So different systems have used different definitions. There's random assignment of weighting for some systems. So some use regression modeling. Some seem to be subjective in terms of assignment of the score for the various criteria. There's been lack of gold standard for validation. So some scores use clinical diagnosis of TB, while others use culture. Then studies where these scores were developed have been hospital-based, and often there's been lack of a control population. And then these scores have been known to have poor sensitivity, and they're likely to only identify the most obvious of cases. So those who have acute onset of symptoms are likely to be missed by these scores. And then methodological issues. So what do you do if particular tests are not available? And I'll just use some examples of some of the scores to highlight these challenges. So for example, the Sturgeon criteria, you see the top criteria that they require over there is a positive culture. So what do you do in settings where you do not have the culture? Okay. Then also tuberculin skin tests, and I've already explained the issues to do with the sporadic availability of the tests and reagents. Keith Edwards score there uses different criteria. Crofton Home and Miller store over there also uses different criteria, but you see they'll have tuberculin skin test there as one, and then it's given a score of 3 where it's positive and on and on. Okay, so this is what the WHO recommends. So careful history, specifically history of TB contact and symptoms, clinical assessment, especially growth assessment, tuberculin skin testing, chest x-ray if available, bacteriological confirmation whenever possible, and then investigations relevant for suspected pulmonary TB and suspected extrapulmonary TB and HIV testing. So I'm just going to show you an excerpt, my next slide, from the Kenya Pediatric TB Guidelines. Okay, so we adapted this from the WHO, and you can see from the history of presenting illness, if they have cough, fever, poor weight gain, lethargy, or reduced playfulness, suspect TB if a child has 2 or more of those suggestive symptoms, okay? Then you go on to ask for history of contact with either an adult or adolescent with chronic TB within the last 2 years. Then you go into the box for physical examination. So does a child have fever? Check about their weight issue, any respiratory signs and symptoms, or any other signs that may be suggestive of extrapulmonary TB. Then you do lab tests. It's encouraged to obtain specimen for expert and culture when indicated, chest x-ray whenever it's available, and then MAN2 tests were available, HIV tests, and then other tests as you think of extra TB. So diagnosis can be bacteriologically confirmed. That's if you have a specimen positive for Mycobacteria TB, but more often than not, the diagnosis will be clinical, as you can see in this last box here. So clinically diagnosed if they have 2 or more of the suggestive symptoms in the first box, plus 2 or more of positive history of TB contact, abnormal respiratory signs, abnormal chest x-ray, positive MAN2, and on, okay? We did a study whereby using those clinical criteria, we developed a diagnostic cascade, and we tried to see to what extent clinicians use these guidelines to diagnose TB in children. And it's of concern in Kenya because Kenya is one of the high TB burden countries, and a recent prevalence survey showed that up to 75% of TB cases had actually presented to health facilities with suggestive symptoms but were never diagnosed. So why are clinicians missing patients with suspected or presumed TB? Our study explored the diagnostic practices based on Kenyan TB guidelines, and it was interesting to note that more than half of all admissions met the initial criteria of 2 or more suggestive signs of TB, but less than 3% got a TB differential diagnosis, and few had TB diagnostic tests done. So this cascade is what I was explaining in the previous slide. So the first box shows all admissions, and then the next box shows that almost 60% of all admissions had 2 or more of either cough, fever, weight loss, lethargy, or growth faltering. So that just brings issues of, if all children who met this criteria potentially now should have gone on to have further screening, history of TB contact, and then investigations being done. And you can see the fallout from the cascade, from those who had suggestive signs and symptoms to those who actually had investigations done, to those who eventually got a TB diagnosis. There's quite a drop in the cascade. So that's just food for thought for us. Even the WHO criteria as we have them, are we really getting all the children with TB? And as we can see from this analysis, that health workers use some other criteria to diagnose TB in children, because if they were to strictly follow the guidelines, we can see the gaps that are being observed there. So in summary, we need a better understanding of which children may have TB and how they present, and the guidelines certainly need to be clearer to help clinicians better select which patients to investigate. We still need a point of care, gold standard TB diagnostic test for children. So I'll stop there, and I believe we'll be handling questions in the Q&A session. Thank you.
Good day, everyone. I'm Olivier Marcy. I have no conflict of interest to disclose. It's my pleasure to give this presentation today on the development of new diagnostic algorithms and score for children with HIV infection or children with severe acute malnutrition. Why are specific diagnostic tools needed in these children? Children with HIV infection or children with severe acute malnutrition are highly vulnerable to TB, as one, they are at high risk of TB disease, two, they are at high risk of death due to TB, and three, they have a high risk of being undiagnosed for TB as they present more disseminated and extrapulmonary forms of disease. They are often post-symptomatic, and at last, their symptoms are largely unspecific. Hence, in these children, new diagnostic tools are particularly needed for prompt TB treatment decision and initiation in order to reduce mortality. In the PANTHER study, we aim to develop a diagnostic score in HIV-infected children with presumptive TB. In this diagnostic cohort study, we enrolled 438 children HIV-infected with presumptive TB that we followed up for 6 months. TB diagnosis was done by local clinicians based on tests available, i.e. clinical features, expert performed on 5 bacteriological samples, chest X-ray, abdominal ultrasound. Clinicians were blinded to the quantiferon gold in-tube result. The reference standard was based on the updated consensus definition published by Steve Graham and collaborators in 2015. We developed 4 models using logistic regression, using less stringent p-values to improve prediction capacity and reduce model overfitting. We selected the best TB diagnostic model based on the area under the ROC curve and parsimony, and developed a score on this model. The median age in the population enrolled in the study was 7.3 years. Median weight for age z-score was -2.5. Median CD4 percentage was 14%, and 39% of the children were on antiretroviral treatment at inclusion. Of the 438 children enrolled, 251 children were classified as having either confirmed or unconfirmed TB. 83% of those had chest X-ray consistent with TB versus 45% in children with not TB or unlikely TB. And you can see that the tuberculin skin test positivity rate was very low in both groups. In addition to a full set of potential TB predictors, the 4 models developed included 1, quantiferon and abdominal ultrasound findings, model 2, abdominal ultrasound finding only, model 3, quantiferon only, or model 4, none of these 2 tests. The same set of 11 predictors remain in all 4 TB prediction models, including positive expert, of course, prolonged fever, unremitting cough, hemoptysis, and weight loss in the last 4 weeks, contact with a seropositive TB case, tachycardia, and chest X-ray features, including miliary, alveolar opacity, and abdominal lymph nodes. And lymph nodes. When including in the model abdominal lymph nodes on ultrasound and quantiferon results, these 2 variables remain significantly associated with TB in all models. The model with the best discriminative ability was model number 2 with ultrasound that had an area under the curve of 0.86, i.e. the green one. We selected the predicted probability threshold corresponding to a sensitivity of roughly 90%, choosing sensitivity over specificity in this severe population. We transformed the model into a score using model parameters and the selected probability threshold, i.e. 38%, and simplified further the score by rounding the threshold to 100 and multiplying the score items by the same number, 58.5, to make it easier to use by clinicians, as it is easier to sum up entire large numbers than small decimal numbers. You can see here the final PANTHER score with all items included. TB treatment should be started as soon as the score is above 100, and TB treatment can be ruled out in those with a full score below 100. You can see here the number of points for each item. For instance, fever lasting more than 2 weeks scores 66 points. And if the child has had hemoptysis in the previous 4 weeks, you have an additional 79 points. So the treatment should be started right away. We measure diagnostic accuracy of the TB prediction score over the development set, i.e. the group of children where all variables entered in the model were available. Specificity was 61% for a sensitivity of 89%. For patients with missing variables, sensitivity varied from 85 to 91%, and specificity varied from 44 to 62%, depending on whether or not we considered missing predictors as all negative or all positive. We suggested using this score in a step-by-step algorithm, allowing thus to minimize the delay to treatment decision based on results as they come, including an early sample collection step for expert testing based on nasopharyngeal aspirate and stool samples. As you can see here, history of contact with a smear positivity case that can be collected quickly leads to a score above 100, hence immediate TB treatment initiation if positive. The next and very important step before wider use and wider recommendation of this algorithm is external validation. In the newly started TB Speed HIV study, we aim at evaluating the accuracy, the feasibility, and the safety of the PANTHER TB treatment decision algorithm. We designed the study as a prospective multi-center management cohort study that will enroll 550 HIV-infected children with presumptive TB. Apologies for the typo here. It should be HIV and not SAM hospitalized. These children will be recruited in Côte d'Ivoire, Mozambique, Uganda, and Zambia. The treatment decision will be based on the PANTHER algorithm, and additional tests will be performed for research, including monocyte-lymphocyte ratio, C-reactive protein, and we will have biobank samples for future biomarker studies. The study endpoints are, on the one hand, cases missed by the algorithm or false negative cases, as that will be reviewed by an expert panel using the Graham classification 2015. On the other hand, cases overdiagnosed as TB or false positive cases that will also be reviewed by the expert panel using here expert opinion as the treatment decision is forced in the model in this situation by the use of the PANTHER algorithm, and hence biases. The 77 patients have been enrolled as of mid-September, and results are expected early 2022. We spoke about HIV-infected children here, and an ongoing effort is also implemented in children with severe acute malnutrition in the TB Speed SAM study. We aim to develop a diagnostic prediction score for children hospitalized for medical reasons. This will be a diagnostic prospective cohort study, really similar to PANTHER, where we will enroll 700 children with severe acute malnutrition that are hospitalized in tertiary referral hospitals in Uganda and Zambia. The treatment decision will be made by clinicians and reviewed by local and international expert panels. The diagnostic tests include detailed clinical features, expert ultra on 3 bacteriological samples, chest X-ray, abdominal ultrasound, quantiferon Golden tube, as well as MLR and CRP. Blood and urine are biobank for future biomarker studies. The score development will be very similar to what we did in PANTHER. We will use also automated variable selection methods to avoid overfitting and reduce model optimism. The inclusions are ongoing in the study. As of mid-September, 147 children have been enrolled. The results are expected late 2021. To conclude, we now have a diagnostic score available and tool algorithm available for HIV-infected children, the PANTHER diagnostic score. It has a good performance overall with a high sensitivity, but a rather poor specificity. However, it should enable quick treatment decision in this very vulnerable population, hence contribute to reduce mortality. And its external validation is ongoing in the TB Speed HIV study. By favoring sensitivity and such a diagnostic tool, we have a consequentialist approach that aims to avoid mortality rather than an essentialist approach that aims to identify true TB. This type of studies has a methodological issues. Of course, the lack of independent standard may lead to incorporation bias. In this context, reference standards such as the Gram classifications needs really standardized assessment and diagnostic decisions. And globally, external validation studies are more complex without a proper reference standard. In this context, more biomarkers are definitely needed to improve diagnostic performance of those tools and possibly move toward a two-step process, including first screening and second diagnosis. Thank you for your attention.
Hello, my name is Norbert Heinrich from the University of Munich, and I have the following conflict of interests. I have received consultation fees from bioMérieux, and my institutions received research support from Beckman Coulter. I would like to report on interim results from the RAPID study on the performance of new screening and diagnostic tests in pediatric TB. Now, RAPID is a complex multinational study which has study sites in South Africa, University of Cape Town, Thedasaris PI, ENS Mozambique, COM in Malawi, and NIMRI MMRC in Tanzania, and CMC Vellore in India. The plan of RAPID is to enroll 1,000 symptomatic children and evaluate 8 new diagnostic tests on their samples. The target confirmation rate in this cohort was set at 20 to 25%. The reference standard in RAPID is imperfect, as in all child diagnostic studies. We are planning to have 2 groups in this cohort. The group with confirmed disease, composed of children with a positive culture and or gene expert ultra to determine the new test sensitivity, and a group of unlikely TB or TB ruled out, which is defined for this analysis by the investigators and will for the final analysis be defined by the endpoint review committee to determine new test specificity. We will enroll 1,000 children of 14 years or less with signs and symptoms of TB in Africa and India, and those will have a standardized diagnostic workup. Clearly, those who have a positive TB lab result will be defined as having confirmed disease, while we will require follow-up of resolution of symptoms without TB treatment to assign a child to the unlikely TB group. And then there's, of course, a number of children who will have an unclear disease status. Some will have had TB, which was just not detected by microbiology, and some will have had other diseases. For this analysis, we are looking at 522 children with a median age of 4.6 years. 81 of those were HIV positive, a relatively low number, and a similar number had moderate or severe malnutrition. Of this cohort, 118 children were defined as microbiologically confirmed TB cases, and 106 defined as unlikely TB cases by the investigators. I'm going to report on 3 new test candidates here: the Fuji Silvam Lam from 167 children with defined disease status, the Find in Rutgers Expert Ultra stool processing kit from 180 children, and the time to be flow cytometry analysis assay from 82 children. The reference standard data shows us that there was a good positivity for almost all sample types, and the test that was giving the highest positivity rates was clearly Expert Ultra, followed by midget culture, followed by LJ culture. And out of those 180 children who had a positive microbiology, 27 had a single Expert Ultra trace result only. So this is actually the situation where one is not entirely sure whether this is a true positive result or not. When we discriminate by age, we can see that the sensitivity was higher in the under 1-year-olds at 67%, and specificity on the right-hand column was at 60%, with only 5 children having a classification of unlikely TB. Whether this is true false positivity or whether there was actually TB disease missed in these children remains to be clarified. We can see that sensitivity in the 1 to 10-year-olds was somewhat lower, and this might be associated with lymph node TB. Looking at stool processing kit developed by Feind and Rutgers, displayed here, sensitivity overall was moderate, somewhat better when expert positive trace call only cases were removed from the reference standard, and specificity was high. When you look at the age distribution, there is a similar trend as in the Fujilan, with higher sensitivity in the infants and in the above 10-year-olds. Now, if we these two tests be taken together and look at the sensitivity of the two tests combined, we see that the overall sensitivity improves to 60%, and especially in the under 1-year-old, sensitivity is 78%. Specificity remains at 60% due to Fujilan finding. In the above 10-year-olds, we see again a higher sensitivity for these two tests combined. Now, looking at the TAM-TB assay that was developed by us together with Beckman-Coulter, funded by HITSIF and EDCTP, we can see that the sensitivity is somewhat higher than for the other two tests, although there's a smaller number of children in this analysis, but sensitivity improves from 56.5 to 75.8% when expert trace only positives are taken out. Specificity at 91.7% seems to be good. And there is no clear distinction between the age groups when you look at the age disaggregated analysis. To conclude, I'd like to emphasize that this is really an early look analysis of partially incomplete, unclean data. The final picture may change, so please do not use this for any decision making yet. For the reference standard, as already said, the highest positivity rate was seen with GeneXpert Ultra, followed by liquid, followed by positive solid media culture, and 25% of the confirmed TB was through the single ultra trace result. For Fujilan, there was a modest sensitivity in this cohort, but it was substantially higher than that of Alerelan, and it was higher in the under 1-year-olds and the above 10-year-olds, with a specificity question still around, which might actually be due to stool contamination of the urine. We will further elucidate that. Stool processing kit had a modest sensitivity, which was higher in the under 1 and the above 10-year-olds, and the combination of those had a good sensitivity in these age categories. For TAM-TB, this small data set shows promise in line with previous evaluations. Now, from the topic, I'd like to point to the other emergency besides COVID and TB, which is climate change. Please, there is really good clarity on the science, so join scientists for future and try to influence your governments to take action to mitigate climate change. I've said this already. Since then, we've had numerous bush and forest fires illuminating the dangers inherent in this development. Let me close by acknowledging the RAPID consortium, the Munich team, Laura, Craig, Sarah, Christoph, and our director Michael, who made this study possible, and the RAPID consortium with the UCT site led by Heather Zar, Steve Graham, our advisor at Melbourne, Marriott Liwaza in Malawi, Nyandan Tingiya in Beira, Tanzania, Celso Kosa at ENS, Mozambique, Pamela at Feind, Balsam Varghese at CMC in India, and Rin at Oxford, our advisor. And of course our funders, the EDCTP, and the German Center for Infection Research, without whom this would not have been possible. So thank you for your attention, and I wish you a good afternoon.
Thank you very much for inviting me to talk today. My name is James Seddon. I'm a clinical lecturer at Imperial College London and at Stellenbosch University. And today I'm going to talk about the contribution of chest x-rays to the diagnosis of paediatric TB. And I think that one of the first things to say that in almost every piece of guidance or any review article, chest x-rays always had a very prominent position in the diagnosis of childhood TB. And yet it's very unclear often what we're supposed to do with chest x-ray, where we're supposed to use it, how we're supposed to use it. And every guidance says there are characteristic features of TB on chest x-ray, but these are often fairly poorly described. And I think for many clinicians, it's fairly intuitive what are the features of TB on a chest x-ray. And as you can see from this image on the left-hand circle is a child who doesn't have TB, and the right-hand circle is a child who does have TB. And there are very characteristic features, the hyaline-lymphadenopathy, the cavities, the miliary picture, which we kind of feel are very characteristic of TB. But there's a large group in the middle where the x-ray is abnormal, but it doesn't really move you towards saying this is TB or not. And this is the real conventional approach to reading x-rays. The first question you ask is the x-ray readable? Yes or no. If it's readable, is it normal? And if it's yes, that can be quite helpful. If it's no, you then say, so it's not a normal x-ray. Are there some of these characteristic features of TB on them? And if there are those features, that might be quite helpful, but if they're not, it's a bit unclear how helpful that x-ray is. Another challenge with reading x-rays is there's a huge difference between different readers in terms of what they see on x-rays. And there have been lots of studies that have done for childhood TB and childhood pneumonia, which have really tried to compare what different readers see. And there's a huge amount of discordance between the way these are read. It's also not clear whether certain features read in a more concordant way than others. This hasn't been really systematically evaluated. Another challenge is the question of blinding. And I think that most people are used to doing a clinical evaluation, and for most other medical tests, such as a blood test, a C-reactive protein test, we have a clinical evaluation, we do the test, and then we interpret the result of the clinical evaluation and the blood test or the test that we've done. And we think we're doing the same thing for x-rays. We think we're doing a clinical evaluation, then we think we're ordering the investigation, and then we interpret the clinical evaluation in conjunction with the x-ray. But actually that's not how most people read x-rays. What happens is we have a clinical evaluation, and then we read the x-ray in the knowledge of that clinical evaluation. So that colors our interpretation of the x-ray. So then when we interpret the combination of them, we're almost doubly reading the clinical characteristics. We're reading it, first of all, in terms of our own interpretation, and then it also has influenced the way we read the x-rays. This is different to the way we use other tests in medicine. And it's not dissimilar to blind tasting for wine. The other thing that's, I think, quite unclear is how we should be using x-rays. So this is on the left, you see an algorithm where for every child you always do radiology and microbiology, but we don't have to do that. And you can see that in the first two, this is for children, two lines going down, you see a child who's presented with TB symptoms, they get evaluated with history and examination, but sometimes you might do the x-ray first and then follow through with microbiology, and sometimes the other way around. And then there are situations where you might be evaluating a child who's been exposed to TB, and you might do all kinds of things, and the x-ray may or may not be done, or it might be very early on in the algorithm, or it might be later. And we haven't really evaluated what is the best way of using x-ray in these diagnostic algorithms. And I think that ultimately there's a good chance that we're not using x-ray in the best possible way to help diagnose children with TB. And what's really nice to see is data-driven x-ray interpretation beginning to come through. There's a very nice study from the Panther group, which was published a few years ago, which actually looked at features in children with HIV and looked at children who were being evaluated for TB and those who ultimately ended up having TB and those who didn't, and looked at which features on chest X-ray had the most concordance between readers, but also what the sensitivity and specificity of those particular features were to diagnose TB. And we're doing something similar in Cape Town with another cohort of children, a cohort of about 600 children. I'm doing this, this is very much the work of Megan Palmer, who's doing a PhD on this, who's shown on this the photograph, where we've taken nearly 600 children, and because they were all read at least twice, independently and blindly, we're looking at X-ray reads rather than consensus views. And about half the reads suggested that these children had TB and half they didn't. And some of them were confirmed and some not. And then we looked at which features what was the sensitivity and specificity of different features to diagnose TB. And it's actually quite similar from the HIV infected group. And what we're next going to do is look at what combinations of features. So although it's one thing to say what do lymph nodes have, but what's the combination of lymph nodes and alveolar opacification? And this will need to be developed using mathematical models. And what this leads to is data-driven algorithms. So this was a very nice, another from the Panther group, which incorporated these X-ray features into an algorithm which combined it with clinical characteristics. And in this algorithm, the X-ray is used only if the score is we haven't made the diagnosis prior to that. So if you go through the algorithm, there's an instance where you don't need to do an X-ray because you're so certain of the diagnosis prior to that. And again, we're now doing this again with the same cohort in Cape Town. This is a colleague of mine, Ken Gunskria, who's developed algorithms, clinical algorithms, within the same cohort of 600 children in Cape Town. He's focusing on the 500 or so HIV uninfected children to complement the Panther study, to look at which combination of clinical features, with or without chest X-ray, are useful to diagnose TB. And really what we should get to is a concept that you don't always need to do chest X-rays to make a diagnosis. And actually this is an evolving concept of decision-making theory, that the test threshold and the test treatment threshold, where if a child really has a very, very low pre-test probability of having TB, we shouldn't be doing tests because it's not going to change our management. And equally, if the child has a very high pre-test probability of having TB, the chest X-ray is not going to change our decision to start therapy anyway. So really we want to be doing chest X-rays in this yellow zone where it's going to make a difference to our clinical decision making. So if we've decided that there is a role for chest X-ray and we know what we're looking for, how do we get people to read X-rays a bit better? And this was a study I was involved in Cape Town a number of years ago, and what it shows really is that it's very hard to teach people to read X-rays. We took 30 or so participants. We gave them a full day of training in how to read pediatric X-rays. We made them read 30 X-rays at the beginning of the day and 30 X-rays at the end of the day, and we saw very little improvement in their ability, even though all of them felt that the day had been incredibly beneficial and had improved their ability to read X-rays greatly. So it just does show that this is very challenging to teach people how to read X-rays better. Which comes on to the idea of computers reading X-rays, and there's a huge emerging literature on how this is being done, but to date it's all been done in adults. And we're working with the group in Radboud to explore the reading of pediatric X-rays. And I think it's going to be probably more challenging than adults, but we've done some preliminary work trying to see if computer algorithms using similar algorithms to adults are able to identify abnormal features, and also what those abnormal features are that would then feed into certain sensitivities and specificities that could complement decision-making thresholds, which would then give you a probability that the child has TB. And ultimately, going forward, I think it's entirely possible that you might have programs where you would be able to input data, ideally handheld, smartphone-based algorithms, where you could put in the age and the gender of the child, their HIV status, their nutritional status, where you are in the world, put in certain clinical characteristics. If you had X-ray to hand, and if it had been digitally read, that could feed in. If you had biomarkers, blood-based biomarkers or salivary biomarkers, that could also feed in. If you had them, you'd have a different algorithm. And at the end of that, you'd have a TB risk. And then you would have a threshold that you would decide that above which you would want to treat, and then you have a treatment decision. So it may be that would treat anyone who has over 70% chance of having TB, and if your TB risk is 78%, then you'd treat them. And this is a vision for the future. So that brings to the end my talk, and I think this hopefully has brought together some of the preceding talks as well. I haven't seen them, and I look forward to some discussion on this. And I would just say this: a lot of this work has been done in collaboration with many, many partners in London and in Cape Town.
My name is Luis Cuevas. I work in Liverpool, the School of Tropical Medicine. First of all, many thanks to the chair for the opportunity to share some reflections after the preceding 4 excellent presentations. And apologies, it's live, but I had a problem with the presentation. So these are my conflict of interest. I have received academic grants from several funding bodies and from Melogic, who is an NGO developing diagnostics, mostly on COVID. I'm also a member of the Global Frontier team. I would like first to start by going back to basics. And that, what I mean is the important lessons that we have learned, and especially now with COVID. And one of them is the importance of diagnostics, is more generally in reaching a diagnosis. Who would say that COVID diagnoses are not crucial for the management of patients? Who will say that now? Who will say that it is not important to guide interventions for surveillance? So the basics of who, where, when, the diagnostics are our eyes. And without them, we are blind. That's a very important lesson that we have learned. Many of us have been fighting for diagnosis for many years, and now are at the forefront of this pandemic. The second is that diagnostic development often doesn't have the needs of children in mind. If you see, even now with 67,000 papers published in COVID diagnostics and other things, the minority are on children. So for COVID, it's the same as TB. We need non-invasive tests that are local, that are rapid, reliable, easy to use, that are low cost. And there is a myriad of new COVID diagnostics in development, and many of them, the initial evaluations are over-optimistic, they're over-promised. They say that they are very fast, they are very simple, they are very easy to perform, but they don't tell them they are in a reference lab, that you have to travel 100 miles. They are not local, and so many things. So the initial evaluations are often conducted by test developers and in controlled environments. They may have a small sample size. They use a pool study design. So this is why I'm saying here, these evaluations here are great because they are often independent. So they are testing these new tools to see if we can really use them. The other thing is that a single test is not enough for everything. Yeah. So do you want to test for screening, followed by another test for risk of disease progression or diagnostic confirmation? All of these, they have different technical product profiles. Yeah. So we need to think when we are starting to develop algorithms, what is the purpose of the test? What is the ideal location? How we will work together. The next one is the evaluations need to follow us to, the evaluations need to allow us to compare evidence. Yeah. So if we think that systematic reviews is a comparison of different studies, but the studies need to be comparable to each other. They need to use, if you use different definitions, then we are comparing apples and oranges. Yeah. We also need to be able to generalize. Yeah. If a test has similar performance in several hospitals in several countries, then we can start to say, well, this test performs very well everywhere, and we can make generalizations. So we can say it works very, very well in this setting, but not in other settings. So that's why, in this case, we need to make sure how are we doing these studies? What are the definitions that we are using? Because then, at the end, what we want is to prioritize. Resources are limited, are finite, and then we need to say which test will perform better in our setting. So many of you in the audience. I hope you did, and if not, they are published and open source. And then Olivia Norbert mentioned the standardized case definition for evaluation of diagnostics in children. So they are nearly 10 years old. Many of you have used them, and we know that they are not perfect. They are second best or gold standard, but this is what we have. And I'm not saying that they are good, but what I'm saying is that this is the measuring tape. So when you have a new test that you have developed or you have evaluated, it allows us to see how it will compare if another person evaluates the test as well. Making the studies comparable, allow us to generalize. So another thing here, please use them. They are not perfect, but use them. They are very useful to all of us. So we had today of potential new algorithms. They great work and it's promising. So we need to reflect a little bit on some general aspects of developing algorithms. And one is that if we use a combination of tests, what is the effect they have in sensitivity and specificity? One test with 90% sensitivity followed by another test where it's 90% sensitivity sounds good. But the likely end sensitivity is 90 times 90. So it's 81% sensitivity. So it's a significant loss of sensitivity because you use one after the other. It's the same with the specificity. If you use a test like X-ray that have 80% specificity, hopefully, and then followed by another test that has 0.9 specificity, then the combined specificity will be around 72%. So it's an important consideration. But also remember that we are not only interested in the sensitivity and specificity, we want the predictive value. Yeah, if there is a positive test, what is the likelihood that that test is really because the person has the disease? And this varies with prevalence. So the sensitivity and specificity is the same in all the settings, but the predictive values will vary depending where you are applying these diagnostics or these algorithms. So then we also need to think, what is the consequences of a false result? I said missing cases or having false positives. What is more important, that you miss a child that has TB, or that you have given treatment to many children who may not have TB? We need to decide what is the priority for these and the right application for these. Maybe you need to build opportunities to rectify the diagnosis in your diagnostic cascade. It's important to say that many papers you see that they say is statistically more sensitive or has a higher low mean, PCR has a higher mean in children with TB than the others. What we want to know is the ability to discriminate between the two. Not is the difference in mean, it's the ability to separate the two groups. Yeah. So often we need to also to prepare tables. What happens if you test about 1,000 consecutive children with different prevalence of the disease? And then you repeat the study in different settings. So not only adding different tests has the effect on sensitivity and specificity, but also it will have an effect on the flow of the patients, in the logistics, and so on. So does it create new bottlenecks? When I see a new diagnostic algorithm that has many lines that cross each other and then go back and so on, does it lead to a new spaghetti junction, we say sometimes in the UK, like the motorways, that there is a moment where they overlap each other and to do a turn, you have to go around and around. So that's very important. Is it simple? Does it end up in something very complex that is very difficult to follow? So also remember, some of you presented tests that were used simultaneously, others in parallel, one after the other. So would that have an effect or long waiting times, or will require multiple visits? How long will it take time? How long will it take to get to results, to make management decisions? So what happens if one of those components is missing? What is the resilience and the acceptability of this algorithm? And also, very important, equity. There has to be, if it is a very good diagnostic algorithm, but only people who can afford it, or people who go to a private hospitals can access it, then that's not what we are looking for. Then what are the cost implications of these? Not only in the cost of the test and the technologies, but opportunity cost benefits. So are we prioritizing those that have the higher needs for these algorithms? So I want to finish by saying that the pandemic will finish one day. It will leave a trail of destruction, loss of life, economic crisis. It does, but it will finish. But then I need to think we are also generating new knowledge. There's lots of discussions in the conference now of all the new opportunities. It has increased awareness of the importance of diagnostics, and it will have many lessons learned. So this is the time that we together harness those openness to keep pushing for better diagnostics for TB in children. Thank you very much, and I hope it transmitted well. I am returning now back to the chair to continue for this discussion. Thank you, Sabine and Eric.
Thank you very much, Luis, and also thanks very much to the conference organizers to allow Luis to have this live session, despite all the difficulties. So we will now begin the question and answer period. Each of the speakers should now be unmuted. We've seen that many of you have already typed questions into the question box, and we will read them aloud to our speakers for their answers. And some questions may be answered in writing by the speakers. And just to get us started, I wanted to ask the speakers how the risk of possible overdiagnosis of children and the consequent treatment of children who do not have TB can be balanced with the benefits of finding more missing cases if a clinical algorithm is used for the diagnosis of TB in children. Jackie, Olivier, Norbert, James, if you have any thoughts on this, you're welcome to share them.
Yeah, thanks, Sabine. Thanks for the question. That's the question, as I mentioned in my presentation that was recorded a few weeks back, is we chose to have a consequentialist approach when defining the threshold. So we knew that we were overdiagnosing TB, because the specificity was not so great. But we showed in the Panther study that children with HIV infection are so at risk of dying from TB that it's better to choose sensitivity over specificity. And we know it's a trade-off. We overtreat some children to save the other ones. And so we do know this and assume that it's the choice that we have to make for now, and indeed are looking forward to more tests that will help increase the specificity. We are in a specific age group which has very little toxicity from treatment and very high mortality risk. So we think this is why we said it's not a true TB diagnostic algorithm, it's a treatment decision algorithm. And this is a decision that we make as clinicians, public health people, and that seem reasonable for now, although we are aiming to improve this in the future.
Great, thanks so much, Olivier. Yeah. Is there anyone else who would like to share their thoughts on this?
Yes, this is Norbert, if I may. I would think that an overdiagnosis, I would fully agree with Olivier that the treatment itself probably does not pose a problem if overtreated. But, well, I mean, an overdiagnosis of TB might actually mean that any other disease is missed that might actually benefit from treatment. So it really depends probably on the setting where this is happening. If you have a child with lymphoma or leukemia mistaken as lymph node TB or so, what options would be available to that child? Thank you.
Thanks for that addition. Jackie, did you want to chip in as well?
Yeah, so I just wanted to give our experience in our setting. As you saw in the presentation, even though almost 60% of patients actually did meet criteria for presumptive diagnosis, we are not having overdiagnosis as expected. There's still a low index of suspicion for TB amongst health workers. So we still have a lot of work to do. So at least from Kenya, I can report we are not overdiagnosing TB. In fact, we still have a way to go with our case detection. Thanks. Over.
Thanks so much. We're going to go to some of the questions that were submitted now. There is one question from Dr. Robina Sempere from Malawi, who has a question I think Jackie could try and answer. Are there any mobile applications where childhood TB scores are uploaded for easy use by clinicians, for example, in real time? She assumes sometimes access may be a problem, but Jackie, do you know of any applications that exist?
Okay, so Robina, I think the problem, and I think you'll have heard from all the other presentations, is that these scores have not been validated as such. So we don't know of any available mobile applications, but the WHO guide is available online, as well as the Union Desk guide. And for us, the Kenyan guidelines are also available online. So what we advise health workers to do is to download the PDFs, which they can view on their phone for quick reference. Over. Thanks, Sabine.
Great. Eric, do you want to ask the next question?
Yes, so the next question is goes to, I think, several questions, not to Olivier, but let me, there's a question from Martina, and it's asked to Jackie, and is asking whether does the Kenya algorithm include assessment of the symptom duration? That's one. And then what was the rationale of the selection of the two or more symptoms to identify children with TB as presumptive? And could you explore what were the main reasons for the clinicians being reluctant to adhere to the algorithms? Over to you, Jackie.
Okay, thanks, Martina. So the Kenyan algorithm, so for presumptive TB, it's any duration. So any duration of cough, fever, weight loss, or fatigue. However, when you come to now a clinical diagnosis, we use persistent cough. So that goes to your second question about the rationale for the selection of presence of two or more symptoms. So we use that in our simplified diagnosis. So if they have two or more of the clinical symptoms, then two or more of either a suggestive chest X-ray, positive MAN2 test, history of TB contact, or abnormal respiratory signs. So we allow the clinician to make a clinical diagnosis of TB at that point, and where they're able to, they collect specimen for bacteriological confirmation. So that was the rationale, to enable clinicians to comfortably make a clinical diagnosis where bacteriological confirmation is a struggle. Clinicians are reluctant to adhere to the algorithm, so we actually went on to do qualitative studies after this, and there's a paper that has just been published this year on what the perspectives of Kenyan health workers were. But in summary, the big issue is that whole low index of suspicion. People just don't think children could be having TB. And then the lack of competence in terms of, now can I comfortably say this is a TB diagnosis? There's still a hesitancy, despite Kenya being a high burden country. So these are some of the issues we are trying to tackle as helping the TB program to address these gaps. Thanks.
Thank you. Sabine, could you ask the next question?
I hope you can hear me well. I'm getting a message from the producer that there's a problem, so I'm keeping my microphone a bit closer. There's a question from Norbert to Olivier about how will you assess specificity if the score forces treatment, and the definition of no TB should include resolution of symptoms without treatment.
Yeah,
Olivier,
thanks.
Can you hear me?
Yes, loud.
Okay.
And thanks, Norbert, for this question. Tricky and which is nested in all our thinking about the study. Indeed, that's a problem. It may not have appeared in my busy presentation, but we will have a review at central level by experts that will not be based on the Graham classification for this group, because we cannot use resolution of symptoms under treatment as a proxy, since treatment is not decided by the clinician per se, is really forced in the model. So it's new. We really had a challenging time thinking about how we would do this validation study, external validation study with this algorithm. We hope it will be convincing. We haven't yet started this review at central level. We are reviewing the missed cases, which are easy to review because these are the children where we apply the Graham classification, but unfortunately in this group we will not be able. But I think it's also a question nested in everything that we do, because when you think about it, depending on whether a clinician is TB treatment, prone, it will start this quickly in either rapid TB or TB speed side or not, based on what is his inclination to start rapidly or not on one set of symptoms. It will influence the reference standard anyway. So we have to live with this. And as Luis pointed out, this reference standard is not so strong.
Thanks so much, Olivier. Eric, would you like to ask the next question, please?
The next question still, I think, still is to Olivier, and it is just the question is, did the score perform different in children under 5 versus those over 5?
I saw Andrew's question. Yeah, thanks, Andrew, for the question. I'm trying to dig into our data because I remember that I did some sensitivity analysis in the different groups. I don't remember, from the top of my head. I remember some challenges, like the specificity dropped in some groups. I would think it's somehow the case in those children. If I'm not sure how I can share the answer later, but I would be happy to do so, Andrew. Thanks for the question. I think it's a key challenge. I remember that the specificity, of course, and no surprise, dropped in those with lower CD4 counts. And I can't really remember if I did this analysis with a threshold at 5, but that's a very good question. And we are hoping, as you understand, really we are in a unique, and thanks to our donor funding agent institution, Unitate, we are able to do an external validation study. And as you know, doesn't happen often. Usually people develop algorithm and never get to validate those algorithms. So this type of question is into what we are aiming to do now. Look at whether when we transfer it to other sites, whether it works as well in younger children, different settings.
Great, thank you. Then there's a question for Luis or anyone else. Thanks for helping us see both the forest and the trees. The $1 million question would be how do we validate a diagnostic when our gold standard is so inaccurate? Luis, can you take that one?
Well, I have $1 million here that I will give it to you if you have a better approach. And I think this is something that we have been wrestling for a long time. Some years ago, I was in TDR at that time, and then we tried to do some systematic reviews. There were 12 different case definitions in 15 different studies. There are still 12 different algorithms for diagnosis used in different settings. And that's why we decided with a group of experts at that time to try to work out these standardized case definitions. And this is what I was saying before. It's not the ideal, but at least what I always say is that it gives us a measuring tape, because we can then compare if you have an 80% sensitivity or specificity for this test, and another person uses it using the same case definition, he gets 80%. We know it's not 80%, but at least the two results are comparable in some ways. So this is what we have. And if you know any other way, it would be possible to then decide whether that other test is better. But so far, what I think I would be very pragmatic and say this is the evidence that we are accumulating using those definitions is better than what we had before. And then I would say it's better that if you use other techniques, it still includes these definitions. You can use latent class analysis. You can adjust for the non-sensitivity of the reference standards. You can use other methods, but at least we need to share this information in a way that is generalizable. It is comparable to each other. So I don't have a better solution for that. But this is what we have. So I know that some of you have evaluated the test, the approach, and some of you say it works better in this way and another. But remember, there's an analogy with surveillance. Surveillance is not perfect. Surveillance has a sensitivity. It detects only, if you see how many cases of COVID we have, and every day we will see the number of cases reported in your country. You know that this is not the 100% of all the cases, but you can estimate what is the sensitivity of the system. And as long as we use it consistently, we know if the numbers are increasing or decreasing. Make the analogy with this standard. It's not perfect, but at least allow us to see the trends, compare things. So that is what my 2 cents.
Thanks very much. I think Norbert would like to chip in as well.
Thanks very much. I would like to try and get the $1 million from Luis. So the question is, I think, a very, very hard one, because with the reference standard having its difficulties, as we all know, our new test estimates for specificity, at least, will probably never be extremely high. Because we are always going to probably miss some cases of TB in children who are recovering without treatment, minimal TB or whatever. And as you probably saw in the rapid presentation, we have these 2 false positive children in the infant age group. And our approach to this is that we will hopefully have data from the other new test candidate on these children, and they are still in the unlikely TB group. But then if we have, for instance, a positive urine lum, if we then also have a host response-based test like TAM-TB, which is positive on those, it's quite likely that those will be true positive cases and not false positive cases. And that's at least something that we would like to present as a sub-analysis. Thank you.
Sabine, can I jump in?
Yes, please.
So yeah, I mean, I think Lewis's point I really agree with in terms of the standard we have and the consensus definitions are not perfect, but they are a consistent definition that we can use between different tests and approaches. But what I would like to say is, I think we need to move away from the concept of making a diagnosis. A diagnosis suggests you know exactly what's going on, and bar a positive culture in a child, we never get a diagnosis in children. So you're left, all the other approaches, the symptoms, the chest x-ray, everything else is probabilistic. And I think we need to move to a stage where we're saying, this child doesn't have TB or not. We need to say this child has 48% chance of having TB or 93% chance of having TB. And we need to derive those numbers from data, which admittedly has to be derived from binary definitions. But the one thing that is binary is whether you treat or not. And so we need to have a sort of a probabilistic approach to quantifying their risk of having TB, and then we put a certain threshold above which we treat. And I think we have to move, I personally think in child's TB, we need to move away from this idea of dichotomous diagnostics.
Cannot agree more.
Thanks very much. We probably have time for one more question. Eric, did you find a good one?
I think yes, there is a key question there, and I think it's in the context of COVID, and I think it's for everyone. Probably Luis and could be able to answer. Do you think that the presence of COVID epidemic should affect the TB diagnosis algorithms for children? What will be the impact? I think anyone could answer, but yeah. Luis, could you give a go first?
Should I say thank you, Eric? That's a difficult one. I was prepared to reply to James' provocative thoughts, but I just want to just say something. Very different to what you do clinically, managing children, than evaluating diagnostics. There are different processes. One will inform the other. But I think, for example, treatment as a test for diagnosis, there are some publications recently that say it doesn't work. Yeah, it adds very little. So, but that doesn't mean that you don't do it. But for evaluating diagnostics, it may not be the best approach. So what will happen with COVID and TB in children? There will be more children who have symptoms. They might come with chronic cough. So that means that it may be that if you screen 1,000 children with symptoms, it may be that the proportion positive for TB may decrease, yeah, because you are screening more people. It may also be that because you are children have cough, maybe you may find that children are accessing the services more for some reason. So it may have many different consequences, and just one measurement whether it will increase or decrease is difficult unless you contextualize it.
Okay,
Great.
you.
Thank you very much. I think we're running out of time, so we wanted to start wrapping up. We really want to thank our speakers as well as the audience for firstly the good presentations and then all the good questions that were submitted. So we've seen Jackie summarizing the different challenges around diagnosis of TB in children, and she also provided an overview of the scoring systems, although none of these really have been validated by the WHO. She shared experience from Kenya, exploring diagnostic practices, which showed that only 3% of children with suggestive signs and symptoms actually received a differential diagnosis of TB, and even less were evaluated. And Jackie concluded that clearer guidelines are needed for clinicians to know which patients to evaluate and when and how to make a clinical diagnosis. And Olivier shared potential new TB diagnostic algorithms and scoring systems for children living with HIV and those with severe acute malnutrition based on the PANTHER study and the validation work under the TB Speed project. The PANTHER score has had a relatively good performance and is undergoing external validation. And Olivier raised some issues around the approach to take in case detection of TB in children, as well as some of the methodological issues that may also have implications for global policies. Norbert shared the performance of new screening and diagnostic tests in potential pediatric TB diagnostic algorithms based on interim results from the RAPID study, which targets sick children suspected to have TB and includes Fujilam, stool processing, and TAM-TB as new tests. The early look analysis showed the highest positivity rate by Expert Ultra, but a relatively high percentage of trace calls, and modest sensitivity of Fujilam, although a bit higher than Alere-Lam, and modest sensitivity of stool testing as well. Then James spoke about the contribution of chest X-ray in the pediatric TB diagnostic algorithm, highlighting issues around concordance and the possible place of chest X-ray in diagnostic algorithms. He challenged us by saying that there's a good chance we are using chest X-ray incorrectly for the diagnosis of TB in children, and presented some suggestions for data-driven algorithms. We were very happy that Luis could still join us and share his thoughts. He shared some important reflections on aspects of the proposed algorithms in terms of combining tests and the logistics of multiple tests, as well as their cost. He also reminded us of looking for predictive value in addition to sensitivity and specificity, as well as the consequences of a false test. So we would like to thank all the speakers for their excellent work in improving diagnostic approaches in a key vulnerable population. And thanks to all the delegates for your active participation. Enjoy the rest of the conference.
Thank you.